Well, thank you so much, Janice, for that very warm and generous introduction. And thank you to everybody in the audience who has come out to hear this talk this morning. It's a theme which I feel is critical to the future of our specialty, and it can be seen as somewhat dry, but I very much appreciate your taking the time to come and listen today. These are my disclosures. I have a couple of financial disclosures, but I think much more important to the theme of my talk today are going to be my academic disclosures. I'm currently the chair of INFACT, past chair of the Canadian Critical Care Trials Group. I also want to acknowledge the support of the Canadian Institutes for Health Research, who've provided some seed funding for some of the work that we've been doing in trying to build collaboration. And I'd particularly like to thank a number of key colleagues, friends, and very, very smart people. The ideas I'm going to be discussing in the projects are not mine primarily, but they really are a collective contribution by people from the Canadian Critical Care Trials Group, from INFACT, from the global infectious disease community, and from some smart biostatisticians. So clinical trials go back to biblical times, but we generally consider James Lind as being the father of the contemporary clinical trial. You're probably familiar with the story. He was a ship's surgeon, and he treated 12 sailors who had developed scurvy. His hypothesis was that scurvy was caused by putrefaction and therefore could be cured by acids. And so he gave them one of 6 different acids and probably a placebo in the form of seawater that included vinegar, sulfuric acid, cider, oranges and lemons, and barley water. 2 subjects in each arm, and within a matter of about 10 days to 2 weeks, the 2 sailors who'd received citrus fruits were back at work, and so he established the link between scurvy and vitamin C. But science in the 18th century was more of a popular pastime than it was the kind of undertaking that it is today. Scientists tend to call themselves natural philosophers, and they were often idle, wealthy people who were driven primarily by curiosity. So Joseph Priestley, who discovered oxygen, was an example of this. Mary Anning collected hundreds and thousands of fossils from the cliffs of Dover and created a very clear picture of early prehistoric fossils in England. But they saw this as being more of a hobby and a pastime rather than a profession or an avocation. This changed, according to a book called The Philosophical Breakfast Club, written by Laura Snyder, in the year 1833. So as science was evolving, an association was created called the British Association for the Advancement of Science. And in the 3rd meeting held in 1833, this group of natural philosophers came together to discuss what they were doing. And during the meeting, an old crone stood up at the back of the room, and it turned out it was Samuel Coleridge. And he waved his finger at them and said, "You people are not philosophers. You cannot call yourselves philosophers. You need a different name." And so William Whewell, who was the chair of this association at the time, said, "Yes, he's right. We do science. And by analogy to those who do art, being called artists, we need to call ourselves scientists." So this is the first time that science emerged as a profession, and it had some profound implications in the 19th century. Public funding of the activities of science, a more structured methodology to the way science was performed, and it really gave rise to a lot of the core observations that occurred during that period of time. Now, the contemporary clinical trial dates back to the work of Bradford Hill back in the 1940s, who was studying treatments for tuberculosis shortly after streptomycin had been developed. And Hill ran what by today's standards would be a small trial, just over 100 subjects, where subjects were randomized either to a placebo or to streptomycin. And he showed that those who received streptomycin did better than those who received the placebo. The reason this is seen as the forerunner of today's trials is that he did a number of methodologic things that really increased the rigor of the trial. He randomized the subjects, he had a placebo, he blinded both the intervention and the outcome assessment, and importantly, he concealed allocations so that you couldn't guess which arm the next subject was going to be enrolled in. Now, critical care, our field, is a young specialty. It's young enough that I was alive before the first intensive care unit was created in Copenhagen in 1953 at the height of the polio epidemic, and I was in grade school when Peter Safar established the first ICU in Baltimore. And as we have evolved, we have begun to develop our own clinical research agenda that is evolving very rapidly. When I was a trainee and when I first started practicing in the 1980s, and when I had black hair rather than white hair, these were some of the trials that really seemed to be shaping what we were doing. They were characterized by several things. First of all, they were often single-center studies. Number of subjects was quite small. There's a study of 75 subjects published in the New England Journal of Medicine. Often they were supported by industry, and the methodologic rigor of these studies was really quite variable. Randomization would be done by techniques that we wouldn't necessarily agree with today. Over the last 25 years, we've really seen an explosion, both in the numbers, qualities, and importance of clinical trials in critical care. This just shows the numbers of published large clinical trials in the field of critical care over that 25-year period. And you can see a steady increase. If you evaluate the impact of these studies by looking at the number of times they're cited, you can see that they are cited more frequently as time goes on, reflecting the fact that we've moved from the beginning of the 1990s to where we are right now to a model which is much more dependent on being informed by data and evidence that comes from well-conducted clinical research and is often translated into guidelines, protocols, etc. Now, also in the late 1980s, occurred something which I think is really fundamentally transforming the way we are doing clinical research in intensive care. In Canada, a small group of intensivists, about 24 of us altogether, got together with the very unstructured vision of undertaking collaborative, multi-center research into problems that we were identifying in the intensive care unit. We were untrained in the methodology of critical care. Some of us had a little bit of a background, but not very much, but quite keen on the concept of working together to undertake clinical trials. We met in this beautiful location, which is Emerald Lake in Alberta in Canada. We spent about 2 or 3 hours discussing how we might move forward. And towards the end of that period, it became apparent that one of two things was going to happen. We were either going to break into fisticuffs and assault each other because we were being bogged down by issues of credit and who was going to do what and what the priorities were and how we were going to structure things and all of the petty things that one fights over, or we were going to find some way to move forward. And so the chair, Tom Todd, at that time said, look, we're going to take a break. You have 5 hours to go out hiking in the mountains, canoeing on the lake. Let's come back at 4 o'clock and we'll see if this can work. And as you might expect, by the time we got back at 4 in the afternoon, after spending some wonderful time in a spectacular environment, all of those issues that seemed to drive a wedge between us had pretty much been resolved, and we moved forward and created the Canadian Critical Care Trials Group and started a research agenda. Our first study was led by Deborah Cook. Deborah at the time was just completing her master's degree and her critical care fellowship at Stanford, and her interest had been in stress ulcer prophylaxis, which had been a theme that had kind of caught the attention of a number of people. Could we be, in fact, causing pneumonia when we're ablating gastric acidity, and could we potentially prevent this by using a cytoprotective agent such as sucralfate? And so we did what was at that time the largest clinical trial, 1,200 patients, and showed that, in fact, H2 blockers were superior to sucralfate in preventing stress bleeding. To our amazement, The work that was done was published in the New England Journal of Medicine. We were quite astonished to find that doing good research and publishing in high-impact journals was not nearly as a remote an aspiration as you might seem. Our next study, or one of our next studies, looked at the issue of preoperative optimization by admitting high-risk patients to an intensive care unit and inserting a Swan-Ganz catheter, if you recall what that device is. This was run by Dean Sandham, who'd had no research experience whatsoever, supported by some methodologists. It was a 2,000-patient study which showed that there was no benefit whatsoever to preoperative optimization. I want to focus on the other big study we did at that time because I think it exemplifies the importance of collaboration and the importance of trust amongst researchers. This is Paul Hébert, who is the current chair of the Canadian Critical Care Trials Group. In 1991 or 92, when he came to us with this idea, he was a graduate student who was working in a lab that was interested in the problem of supernormal oxygen delivery, a big theme in the 1980s and early 1990s. And Paul came to the trials group and said, listen, I've got a great idea for a clinical trial. You know that we all transfuse patients at when their hemoglobin drops below 10, but what if we targeted a normal hemoglobin level and transfused them once their hemoglobin dropped below 12? Can we increase oxygen delivery and therefore improve clinical outcomes? And so we sat around as a group and discussed this, and a wonderful session that lasted probably about 2 hours. We realized at the end of that session that although Paul had articulated a good clinical question, there was actually a great question that we all thought was a really important thing to study, and that was, why did we transfuse patients at this arbitrary level of 10? And so we undertook a bunch of background work which led to the TRICK trial, which showed that in fact patients do as well or even better if you withhold transfusion below a threshold of 7. So over that 25 years or so, the Canadian Critical Care Trials Group has evolved to an organization that has more than 300 members, interdisciplinary, multi-professional. We have 60 to 70 active research programs, more than 250 publications. And probably the most important element of it is that these are clinicians who have learned to do clinical research by working together in an organization that is devoted to doing that research. And so we have multiple aspects of community mentorship directed not only at trainees, but also the most senior people in the group. And I think all of us would agree that the major education we've received in clinical research has come through our engagement in the Canadian Critical Care Trials Group. We've even done studies that have focused on the process of doing research. For example, we've asked the question, what are the benefits and potential pitfalls of co-enrolling patients into multiple trials? What does it mean when you're running several trials in an ICU in terms of trial recruitment? We have over time evolved a model of research which has proven very effective. We call it a programmatic research model, which emphasizes that you're not simply doing a clinical trial, you're studying a clinical question. And the tools to study that question are really quite variable, from systematic reviews to surveys to observational studies to pilot studies. And once you've done a clinical trial, informed by what you've learned from your background work, then there's a imperative to try to translate that information so that it maximally benefits patients. So that was the Canadian experience, and it was a model that gained traction elsewhere. The first country that really picked it up was the Antics group, the Australian New Zealand Intensive Care Society, created their clinical trials group, which very rapidly grew to be a potent, dominant organization in investigator-led clinical research. It was founded in 1994. They've published hundreds of papers, including 10 papers in the New England Journal of Medicine. They've done the largest trials ever done in our specialty. For example, this one, the CHEST trial, looking at hydroxyethyl starch. And they have taken the Canadian model of having fun at meetings and taken it to another whole level. But they have also been able to integrate clinical research very extensively throughout the Australian and New Zealand intensive care clinical community. In the United States, in the mid-1990s, ARDSNet was funded and undertook some landmark studies that have really changed the way we ventilate patients, and particularly patients with ARDS. ARDSNet has now become the PETAL network and is developing several important clinical trials following forward from their work on ARDS, but with more of a focus on the early prevention of acute lung injury. But it's not just Canada, the United States, and Australia. In Europe, for example, the German SEPNet has done a number of studies, including this one, looking at intensive insulin therapy. In Scandinavia, 4 countries came together to create the Scandinavian Critical Care Trials Group under Anders Perner, and they've published a number of important studies, including a recent study on the role of hemoglobin, of transfusion in patients with septic shock. In Ireland, the Irish Critical Care Trials Group has undertaken a study of simvastatin in the acute respiratory distress syndrome. The French RIVA network has done a number of important studies, including this particular one looking at high-flow oxygen through a nasal cannula in treating acute respiratory failure. In addition to national groups that have kind of come together organically to conduct clinical research, there have been research institutes that have, in a sense, borrowed on this model to undertake clinical research. ICNARC, led by Kathy Rowan in the United Kingdom, was one of the groups involved in the recent resuscitation trials. The George Institute works very closely with the Antics clinical trials group and has done some important work. In Pittsburgh, the CRISMA lab, led by Derek Angus, has played a major role in both conducting research and thinking about the process of clinical research. You can even go outside of Europe. In Brazil, the Brazilian Research and Intensive Care Network, led by Fernando Botza, published a paper in JAMA last year looking at the value of a checklist in the intensive care setting in improving clinical outcomes. And they're a dynamic, very active network, about 140 different ICUs who are involved in them, and they will really be a major force in ICU research in the future. China, there's a Chinese critical care clinical trials group led by Bindu. They have done a number of observational studies and will very shortly, I believe, be in a position to undertake and collaborate in clinical trials. There's an Asian critical care trials group that includes about a dozen countries from Korea to Singapore to Saudi Arabia. And again, they've also been actively involved in both observational studies and through Yassine Arabi in some clinical trials in Saudi Arabia. But it even goes beyond these kind of high middle income countries. There are groups emerging in Latin America. The LACTIN network, based in Chile, has about 14 different countries involved and has just completed their first observational study and a study on Zika in the intensive care unit. There's an Asian study in Southeast Asia called SEARCH that includes Bangladesh, Sri Lanka, Nepal, India, and Pakistan, which has just come together. And there are even 2 groups in Africa, one in sub-Saharan Africa called ACART, and one in North Africa called the North African Network for Intensive Care Medicine Research. So this is really a model that is kind of welling up around the world as a way of conducting research. And the critical element of that model is that it is led by clinicians, and the questions come from the experience of those clinicians in looking after critically ill patients on a day-to-day basis. It's a powerful model, and we evaluated this earlier, I guess it was last year, looking at just under 400 large clinical trials in critical care that were published over a 22-year period. And what you see on this slide is that of those studies, still the bulk of the studies that are being done in critical care are emerging from either single-center trials or small trials that involve 2 to 5 centers. Industry is not that actively involved in critical care research. Only about 20% of critical care trials are led by industry. Multi-center trials groups are still the minority, only about just over 10%. But if you look at the impact based on the citation rate, you can appreciate that it's these studies coming from the multi-center investigator-led trials groups that are really having the impact reflected in their being cited in other papers. And so much more than even multi-center ad hoc groups, which have about half the impact. So over the last 5 years, for example, there have been 27 papers in the New England Journal of Medicine that have come from these investigator-led groups. And it's important to recognize as well that what these groups study falls under the rubric of comparative effectiveness research. They're not investigating new drugs. They're not coming up with magical new cures for critically ill patients. They're asking very fundamental questions. How do we prevent clots? How do we prevent stress ulceration? How much fluid should we give? How do we ventilate a patient safely? How do we optimize renal replacement therapy? But this is what we're interested in. And so the citations to these comparative effectiveness studies are much more frequent than are those to studies where we're evaluating new technologies. And I'll say a bit more about this a little bit later. So it was perhaps inevitable that these groups that were taking a very similar kind of approach to the process of clinical research should come together and see if they might collaborate more fully. And so in 2008, representatives of about 12 to 15 such groups met in Granada in Spain and agreed to launch the International Forum for Acute Care Trialists, or INFACT. So this is the mission statement for INFACT. It seeks to improve the care of acutely ill patients throughout the world through the promotion of high-quality clinical research into the causes, prevention, and optimal management of acute life-threatening illness. A couple of things I think are important to emphasize about what INFACT is and what it is not. It is a network of networks, and we anticipate that the bulk of the research will be done and led by the individual networks who are members of INFACT, and not by INFACT as some kind of controlling superstructure. To this end, the F in INFACT stands for forum. We're not a federation. We're not trying to in any way set standards or impose approaches to doing clinical research. Rather, what we want to do is to create a forum where people who are doing this can come together, share experiences, develop common projects, and collaborate. To that end, we try to be as inclusive as possible, and we have really begun to welcome emerging groups from other areas of the world. I think it's also important at this stage that this is not a commercial undertaking. We are actually unfunded. We have no membership fees, and apart from 2 small meeting grants from the CIHR, we've really not had any funding to support this work. And that's a double-edged sword, but I would argue that, in fact, being free from the constraints of funding can be a very valuable thing because it allows you to focus on the science and the collegiality rather than on who controls the money. So our first activity was actually back in 2009. This was when H1N1 became such a problem around the world, and we realized that if we were going to collaborate, this was the opportunity where we not only an opportunity, but we really had to collaborate. And so we committed ourselves to undertaking a global study of critically ill patients with H1N1. Primarily observational studies, and we were able to bring together groups, 5 or 6 different groups, to pool data so that we could have a database of about 5,000 to 8,000 ICU patients with H1N1-induced critical illness and really understand the phenotype of this. But we were also able to launch 3 randomized clinical trials that recruited small numbers of patients because we learned that the time lag to launching a trial was such that it really was not feasible to initiate the process during a pandemic. We also published the materials on the process of running research during a pandemic, and in particular the whole question of research ethics and how they might differ or be expedited to meet the needs of a rapidly emerging and unknown threat. A couple of important things came out of this activity. One of them was our collaboration with a group called ISARIC, who were set up by some large funders to bring the ID community together to facilitate pandemic-type research. And so Steve Webb from Australia and Srinivas Murthy from Canada, who you see on this slide, have led an observational study called Sprint SARI. The idea here is to do a short period incident study over a week in all around the world, patients admitted with severe community-acquired pneumonia, admitted to an intensive care unit with severe community-acquired pneumonia, for two reasons. One, so that we can understand epidemiology, risk factors, outcomes of community-acquired pneumonia, but even more importantly, so we can build those interactions between intensive care units, create those networks and collaborations that will allow us to more rapidly transition to meet the needs of future pandemics. We have an outcome measures working group that's led by Brona Blackwood, Terry Huff, and Bronwyn Connolly, who are quite active right now. We are developing a way of thinking about and organizing outcomes for clinical trials. We've been developing core outcome measure sets in areas like mechanical ventilation, subarachnoid hemorrhage. We're undertaking a systematic review of what happens when one uses different models of mortality as an outcome in clinical trials, how it's impacted by the time of ascertainment, et cetera. And we're really working on trying to get the patient perspective on outcomes so that we can understand some of the longer-term outcomes from critical illness, collaborating very closely with Dale Needham in the very important work that he's doing in long-term outcome measures. This is Charles Gomersall and Shay McGuinness from the Antics group, who have put together a program called Basic Clinical Research, which aims to provide education for neophyte researchers in the basics of undertaking clinical research. There's a manual that's over 100 pages long, beautifully put together, and we recently held this course for the first time in Karachi, Pakistan, for members of the Search Network, and the idea is to run it in other locations to really build up clinician comfort with the process of doing research. We've spent time with emerging networks such as the LACTA network in South America and the Asian network in Singapore at their meetings, and kind of mentoring them on the process of moving forward as a clinical trials group. Being an international body gives us an opportunity to think about international epidemiology, and so these are a couple of studies we've done. We've looked at access to urban acute care services in an initial pilot study of 7 cities that we hope to roll out to become a large and representative study of acute care access around the world. We've come up with estimates of the global incidence and mortality of sepsis as it's treated in hospitals, and estimated that there are about 31 million cases a year based on that. There are challenges associated with large-scale epidemiology, and probably the most important one is what is the denominator. And so we have a group that call themselves the Denominator Club, who are focusing on how do you come up with a reliable denominator estimate. And they're using techniques that have been developed by the World Bank and by the Global Burden of Disease Project. This is David Wallace, who is undertaking a very exciting study that we're collaborating on that is trying to map global capacity for acute care, to create an electronic picture of what is available around the world, and it will be a potent tool both for research but also for resource planning, and particularly in the need of emergency resource planning. We've just recently been funded to undertake a study on antimicrobial resistance. The concept that we're testing is, are there ways that we might be able to set up a global surveillance network for antimicrobial resistance using a representative group of ICUs around the world? And so we're collaborating with David in this and with the Access network that he is building. A key question coming out of this actually is looking at Acinetobacter baumannii infections in critically ill patients. This is a big problem in developing countries, much more frequent there, and a high attributable mortality. And it's quite likely that Acinetobacter has as its reservoir the hospital water supply, taps and pipes in the hospitals, and that some simple infection control measures might be able to alter this. So the Antics study is testing this hypothesis, and in the process seeking to build capability and capacity for research in some of our emerging group networks. A key element, though, is building collaboration, and to this end, we were supported by CIHR to hold a meeting last year in Whistler, British Columbia. I probably don't need to dwell on the value of collaboration, but I think there are some things. One can certainly look at the generalizability of the results, at the efficiency of generating new information. But to my mind, the single most important thing is that we are a global profession and a global community of people looking after critically ill patients. And building camaraderie and scientific integrity is critical, and collaboration is fundamentally important to that. We find as well that when you look at things on a collaborative level, you see them slightly differently. So Greet-Vandenberg's study on tight glucose control suggested we should target normal glycemia and led to multiple efforts to try to come up with ways to do that. Large amounts of money were spent on strategies to normalize blood glucose in critical illness. And then the Nice Sugar study said that Greet had a brilliant idea in the need to control blood sugar, but if you looked at it on a larger scale, perhaps too much of a good thing wasn't very good for patients. And if we were a little bit looser on blood sugar targets, patients actually did better. So it speaks to the importance of generalizability. Similarly, with the landmark work that Manny Rivers did, taught us about resuscitation and the importance of early resuscitation in critical illness. But he was underpowered to look at the how and the what we had to do. And so guidelines like the Surviving Sepsis campaign had to make recommendations about the use of dobutamine or transfusion without being able to do that. Now the 3 Process, Promise, and Arise studies have been conducted, and we see 2 things. One, that we have taken up the message of resuscitation, and patients are even doing better than they did in the experimental group in Manny's study. But 2, those fine points are not the next frontier of questions, and we need to better define what the next key issues in resuscitation are. And they may be things topics such as the Scandinavian group is now looking into, of more restrictive approaches to early fluid resuscitation. So there are a number of models of collaboration that are kind of emerging. One's an informal one that's exemplified by the ABLE study that we recently did looking at the age of blood in critical illness. Here there's a lead group and ad hoc participation by members of other groups. So one group's really controlling the show, the others are providing patients and getting the names on the paper, but it's very much a single group, and the additional collaboration is to increase study power and efficiency. Another model is the Process, Promise, and Arise model, where you have different protocols on a common theme, harmonized in terms of the time, the size, the key questions and endpoints that will be addressed, and an agreement to pool data in an individual patient data meta-analysis. And this is one that I think can work really quite effectively. Integrated studies are more difficult, but there have been some of these as well. The Nice Sugar study is an example of that, where 2 or more different groups agreed to conduct the same study using the same protocol to report this in a single publication and to share ownership and responsibility for the final work. But there's a new model that Derek Angus spoke about at this meeting last year, which I think we're getting really quite excited about, and that's called the platform trial. A platform trial is a trial that studies a disease rather than an intervention. It uses adaptive designs, and you can look at multiple different interventions that can be reported individually as individual papers, and it can be simultaneously conducted by multiple different groups. So this trial, REMAP-CAP, is now funded in Australia, New Zealand, and Europe, and we're seeking funding in Canada, and hopefully we'll be able to go forward with it to look at a number of different interventions in severe community-acquired pneumonia. They say you should never look at how sausage is made or how politics is done. The opposite is true for collaboration in critical care research. The single most important thing is the fun and camaraderie that is experienced by those who take part in it. There are some challenges, however, and one of them is authorship. In a time when having your name first or last on a paper is viewed importantly by promotions committees, etc., how do you deal with authorship in a large trial? Well, the physicists have kind of figured this out. They've realized that if you have something like the Large Hadron Collider, I've taken out 3 slides there, with multiple people working on it, you give them credit for it. And so that particular paper had over 5,000 named authors. There's no reason why we can't be thinking similarly. I think the age of the sage and the brilliant principal investigator is really past. Funding is a real challenge. Brian Cuthbertson, while he was in the UK, developed the Sutoko Study, looking at selective digestive tract decontamination and particularly focusing on its effects on microbial ecology. This study was conceived as a multinational study. It was funded in Australia and New Zealand, but was not funded in the UK, was not funded in Canada, and its future is somewhat uncertain right now as we try to come up with funding for it. So there's a real need to be able to convince funders that they need to step up and support these new models of research. It's not going to come from industry. If you look at new drugs that were introduced over the last 12 years, you can see relatively few new drugs have been brought in fields of acute care. Most of them are in areas like oncology, rheumatology, etc. If you look at trials in clinicaltrials.gov, not only are there fewer trials in critical care, but only about 15% of them are actually funded by industry. So we need other sources of funding to be able to do this research. We've tried to get that funding from large international foundations, but they tend to see critical illness as a luxury of the developed world and focus more on prevention and community-type interventions in low-income countries. This is changing a bit, and I think our engagement in pandemics like SARS, H1N1, and Ebola is changing this. And I think the World Health Organization now has come to the realization that critical care plays an important role in public health and needs to be supported. For example, during the Ebola outbreak, it became apparent that rather than focusing on siRNA against the Ebola virus, what we really needed to study was how do you give fluids to a patient who's dying from dehydration, from diarrhea and vomiting. We also found that when you improve clinical care, you can reduce the costs of that care. So we undertook the PROTECT study looking at DVT prophylaxis with either low molecular weight heparin or unfractionated heparin. Rob Fowler undertook a cost-effectiveness analysis of that study. The study showed a small reduction in rates of pulmonary emboli, but no differences in mortality with low molecular weight heparin. The economic analysis showed that if you switch to low molecular weight heparin, the average ICU could save $1 million a year. So there's a huge imperative to be undertaking this research. The SAFE study in Australia and New Zealand, it's been estimated they can save $150 million by shifting from albumin to crystalloid in resuscitation. So the healthcare system and society has a lot to gain from what we do. Now, research is dynamic, just as practice is dynamic, and as we now do things we didn't do even 10 or 15 years ago, we have to study things that we have incorporated into guidelines because we may not be helping our patients, may be harming them. I mentioned our first study in Canada of stress ulcer prophylaxis. Deborah is now is undertaking a multinational trial that addresses the question, is placebo superior to pantoprazole in stress ulcer prophylaxis in reducing rates of ventilator-associated pneumonia and Clostridium difficile colitis? This is going to be critically dependent on collaborations with the Australians, hopefully with the Scandinavians, and possibly with the Brazilians. These are international questions, and we all ask these questions. So we're now moving into an era where research has opportunities that it hasn't really had in the past. We have an imperative to come up with the best possible scientific evidence for the care that we provide our patients, and that comes from the evidence-based medicine movement. We have groups of clinicians who can ask these questions and conduct these trials in the ICUs they work in. We have the era of big data and electronic health records and tools to be able to collect data in real time, efficiently, and to manage very, very large data sets. And we've got new research designs, such as the platform trial, that actually allow us to integrate research into clinical care. So I think we're moving into an era where the boundaries between clinical practice, research, and quality improvement are going to blur and ultimately meld into a single entity, so that we will see that the capacity to do clinical research will become a core competency as much as the ability to intubate or start renal replacement therapy. We will see research done in the context of a platform trial as the best method of quality improvement, a continuously learning healthcare system that is updating and improving care as it generates evidence on that. This will be enabled by the fact that we are functioning as a global community. And probably the most important concept here is that as we move to integrate research with clinical care, we can move the funding from the relatively limited coffers of granting agencies into the healthcare system, because the healthcare system will benefit not only from improved patient care, but also from reduced costs. So we live in an absolutely extraordinary period of time. In my lifetime, it's the first humans have been able to see for themselves rather than simply infer that the Earth is a sphere. We have been able to understand biochemically what the basis for life is and how life is passed from one generation to the next through the unraveling of the structure of DNA. I suspect every one of you in this room has a smartphone, and through that smartphone you can not only contact the people you love, you can check things out on the internet, you can tweet about how much longer is this guy going to ramble on for, and you can check out anything that I've said by accessing the internet. You can also do research on a large scale because the smartphone can be used as a data collection tool. So we have many, many opportunities. We also have challenges. We live in a world where the population is growing at an uncontrollable rate. We have major problems with global warming and climate change, and with the roiling of political differences, collaboration on the one hand, nativism and protectionism on the other hand. But I think for those of us who work in the ICU field, and particularly for those of us who are privileged to not only take care of the most vulnerable patients in the healthcare system, but also to ask the questions, how can we do this better, and how can we make that care more congruent what the patients want. The opportunity to collaborate not only with our peers in our own cities and our own countries, but with colleagues around the world is an extraordinary opportunity to really, in a sense, take a stand against some of the pessimism and uncertainty that we face now. And I think it's a core component of the research mission that we are engaged in. Thank you for your attention this morning.